Welcome! In this series of videos, you'll learn about obesity prevalence and trends. There are 3 learning objectives for this series of videos. After viewing these videos, you will be able to 1. Define and interpret indicators of obesity. 2. Describe health outcomes associated with obesity. 3. Explain historical trends and the current prevalence of obesity in the United States. This video will focus on the first learning objective, defining and interpreting indicators of obesity. The most commonly used indicator of obesity is body mass index, or BMI. BMI is calculated by taking an individual's weight and dividing it by their height. The value obtained represents weight status, or an individual's weight considering their height. This metric can then be classified as underweight, normal weight, overweight, or obese using standard thresholds as illustrated in this table here. BMI is a screening tool, not a diagnosis. It merely indicates the need for further behavioral and metabolic assessment to determine an individual's health risks and need for intervention. How is BMI calculated? The formula used depends on whether your weight and height measures are in kilograms and meters or pounds and inches. For kilograms and meters, the formula is kilograms divided by meters squared. For pounds and inches, the formula is pounds divided by inches squared times a constant. Note that there are also many BMI calculators that you can find online. An example of one published by the CDC is in the link below the table. Let's look at the CDC's BMI calculator tool together. On the CDC's website, they have a number of tools and resources that you can use to educate yourself or others about BMI and related health conditions and behaviors. As you can see, for this BMI calculator, you merely need to indicate your units, English or metric, enter your measured values, and click Calculate. This calculator will then calculate BMI for you, as well as the BMI classification, and provide some additional education about health risks associated with that classification. So let's talk about how to interpret BMI when we're working with adult populations. After BMI is calculated, it can be classified into one of these weight status classifications that are widely accepted and used in research and clinical practice. A BMI that is below 18.5 kilograms per meter squared is classified as underweight. A BMI between 18.5 and 24.9 kilograms per meter squared is classified as normal weight. A BMI between 25 and 29.9 kilograms per meter squared is classified as overweight, and a BMI that is 30 or more kilograms per meter squared or 40 or more kilograms per meter squared is classified as obese or extreme obese, respectively. The terms overweight and obesity have clinical definitions that illustrate how they represent body composition. Overweight is defined as an excess amount of body weight that may come from muscles, bone, fat, and water, whereas obesity is an excess amount of body fat. One of the reasons why we use BMI as an indicator of weight status is because it correlates strongly with more robust measures of body composition, such as percent body fat and waist circumference. The figures on the right represent these associations. Let's walk through them together so you can understand these correlations. These top figures illustrate associations between BMI and percent body fat measured by DEXA scans, which are considered the gold standard measure of body composition. The graph on the left is for men and on the right is for women. As you can see, BMI is on the x-axis and is predicting percent body fat on the y-axis. This curved line here and the cluster of data points showing a trend along the curved line illustrate a strong positive correlation between BMI and percent body fat, meaning that as BMI increases, percent body fat also increases to a point, and we see it levels off at higher BMI levels. This association is similar for women, where as BMI increases, percent body fat also increases and levels off at the highest BMIs. These graphs here represent associations between BMI on the x-axis and measured waist circumference on the y-axis. Note that these acronyms represent the BMI classifications of underweight, normal weight, overweight, and obese, class 1, 2, 3, 4, or 5, which represents different severities of obesity. The red line on these figures illustrates the clinically defined cut points for waist circumference at which we see increased health risks. Similar to the figures above with percent body fat, we see a strong positive correlation between BMI and waist circumference, in that increases in BMI are associated with increases in waist circumference. The association between BMI and waist circumference is similar in men and in women. Taken together, these data provide evidence that BMI is a useful proxy for body composition and can be used as an initial screening tool to determine individuals who are in need of further and more rigorous body composition assessment. Okay, so let's now discuss how we interpret BMI for children. When thinking about weight status for children, we have to consider their developmental stage and developmental differences in body composition. For this reason, we don't use raw BMI to classify weight status for children. Instead, we use growth charts published by the CDC to standardize BMI to percentiles or z-scores. This allows us to compare a child's BMI to reference children of the same age and sex. The reference data for these classifications come from surveys of U.S. children that were conducted between 1963 and 1994. This sample is considered to have a more normative distribution of weight status than present-day children because rates of overweight and obesity were much lower back in the 60s, 70s, and 80s compared to present day. These BMI percentile scores can then be classified into similar weight status groups used for adults. A child with a BMI percentile that's less than the 5th percentile is considered underweight. A BMI between the 5th and the 85th percentile is considered normal or healthy weight, whereas a BMI in the 85th to 95th percentile is considered overweight, and above the 95th is considered obese. Standardizing children's BMI is important because it allows us to account for developmental differences in what's considered normative body composition. Healthy body composition for an infant is much different than for a young child, which is much different than an older child or a teenager. These silhouettes illustrate differences in normal body composition for a 6-year-old who has much higher body fat percentage compared to a 10-year-old who has a much lower body fat percentage. As you can see in the silhouettes, the 10-year-old is much longer and leaner than the 6-year-old. These differences would be even more pronounced if we compared an infant to a teenager. Thus, by standardizing BMI to sex and age-specific references, we're able to more accurately interpret children's weight statuses in ways that are developmentally appropriate. Let's look at a CDC growth chart together so you can understand how to use this tool. I'll first note that there are separate growth charts for boys and girls. This is indicated at the top of the chart. On the x-axis, we have age in years. The y-axis represents calculated BMI, which is calculated using the same formula we previously discussed, kilograms divided by meters squared. You can see the curved lines across this chart represent the percentile curves. So a BMI that falls on any of these lines corresponds to the indicated percentile on the right-hand side, ranging from the 5th to the 95th. There's also space to record the child's name, a medical record number, and their data over time, so a child's weight status can be tracked as they develop. So let's talk about how we would actually use this growth chart to determine the weight status for a child. So if we had a 7-year-old boy with a calculated BMI of 16, first we'd find his age on the x-axis. Then we'd find the line on the y-axis that corresponds with his BMI of 16. We would determine where these two lines intersect, and that indicates his BMI percentile. For this particular boy, his BMI percentile would be considered in the 60th percentile. We can interpret this value to mean that this boy has a BMI that is higher than 60% of the children in the age and sex-specific reference group. If we have a 14-year-old boy with a calculated BMI of 23, we can similarly find his age on the x-axis, his BMI on the y-axis, find the intersection of these two lines, and see that his BMI percentile would be the 86th. That means that this 14-year-old boy has a BMI that is higher than 86% of the children in the age and sex-specific reference group. Now let's look at the growth chart for girls. You can see this is indicated on the top of the chart. This growth chart is very similar, it's just based on data for girls in the reference population. So if we were to use this chart to determine the weight status for a 4-year-old girl with a calculated BMI of 18, we would similarly find her age on the x-axis, find her BMI on the y-axis, determine where these two lines intersect, and see that this girl has a BMI in the 95th percentile. This means her BMI is higher than 95% of girls in the age and sex-specific reference sample. One more example. If we have a 17-year-old girl with a BMI of 18, we would find her age on the x-axis, her BMI on the y-axis, and we see the intersection of these 2 points is at the 11th percentile. So note that these two girls have the same calculated BMI of 18, but their BMI percentile is very different, the 95th versus the 11th. This is a great illustration of these developmental differences in how we interpret BMI. For a 4-year-old girl, a BMI of 18 represents a very high weight status relative to age and sex-specific peers. For a 17-year-old girl, a BMI of 18 represents a weight status that was on the lower side of her age and sex-specific reference group peers. So I want to remind you that these growth charts are to be used with boys and girls who are between 2 and 20 years of age. So what do we do for infants? Well, we use a similar approach but different growth standards. Instead of using the CDC growth charts, we use the World Health Organization growth standards, which are very similar to the CDC growth charts in that they provide age and sex-specific charts and tables that we can use to calculate standardized weight status metrics for infants. We have a couple different options for what metric we can use, but these growth standards illustrate percentiles or z-scores for BMI for age, weight for age, or weight for length. Note that I'm using different terms when I refer to the CDC growth charts or the references and the WHO growth standards. The difference in terminology is on purpose, and it stems from differences in methodology in terms of how these growth charts were created. A reference describes how children grew in a certain place or time, so the CDC growth charts are based on a reference sample that was representative of children at the time the data were collected. In contrast, the growth standards reflect how children should grow when well nourished and cared for. And these standards are achieved by careful sampling and methodology so that the population that's surveyed reflects this ideal. So the data for the WHO growth standards came from a huge multi-center growth reference study that was conducted between 1997 and 2003. This study was a major effort to make sure that we had high-quality longitudinal data on how children grow when they're well nourished and cared for. These data include weight measurements of babies between birth and 24 months of age. As you can see, the sample size was quite large, almost 19,000 observations for 903 distinct children. All of these babies were breastfed. 100% were breastfed through 12 months of age, and on average, complementary foods and beverages were introduced around 5 months of age. These babies were from Brazil, Ghana, India, Norway, Oman, and the USA, and special effort was made to make sure they were predominantly breastfed babies. Exclusion criteria included factors that may impair infants' growth, such as maternal smoking during pregnancy or lactation, premature birth, late birth, multiple births, or other chronic illnesses. So I want to emphasize that these growth standards support two important ideas related to infant growth and development. The first is that we consider the growth of the breastfed infant to be the gold standard for healthy growth. Second is that infants and young children have the potential to grow similarly regardless of their race, ethnicity, and place of birth, given they are breastfed, they are living in a healthy environment with sufficient resources, and they have adequate nutrition. So these growth charts give us a great metric by which to assess infants' weight status. So let's go through these growth charts together so you can understand the different components. In some ways, they are very similar to the CDC charts, but there are some important differences. We see the age in months and years is on the x-axis. And on these particular charts, which represents BMI for age for girls, we have calculated BMI on the y-axis. We have the percentile curves in different colors, which represent the percentiles that range from the 3rd to the 95th. Note that the specific metrics in the sex is represented at the top. We will look at some different charts in subsequent slides. So these BMI for age charts can be used to identify overweight and obesity in infants. Let's look at how we would use this to classify the BMI for a boy who is 12 months of age. We would find the age on the x-axis, the BMI of 16.8, which was measured and calculated, on the y-axis. We would find the intersection between these 2 points and see that this boy has a BMI percentile at the 50th, meaning his BMI is fairly average for his age and sex. We can also look at a baby's weight for length, which is a little bit different in that it can identify risk for overweight or obesity, but does not require age. So here we have a weight for length chart for girls, which has length in centimeters on the x-axis and weight in kilograms on the y-axis. And so if we knew a baby's weight and length, we could get an assessment of their weight status based on these 2 measures. So if we have an infant girl who has a weight of 10 kilograms and a length of 75 centimeters, we can find the intersection between these 2 lines and see that this girl's weight for length would be classified in the 85th percentile. We can also look at an infant's weight for age, which can be used to identify children with low weight or high weight, and we also use this to identify slow or rapid weight gain when we look at change in weight for age across infancy. Here is a weight for age growth chart for boys, and if we have a boy who is 11 months of age, we can plot that on the x-axis. If his weight is 7.8 kilograms, we can plot that on the y-axis. At the intersection of these points, we can see that this boy's weight for age is in the 3rd percentile. So now that you have a better understanding of how to calculate and interpret BMI for infants, children, and adults, I want to remind you that BMI and BMI classifications are screening tools, not diagnostic tools. When we have an individual whose weight status is classified as obese, this indicates the need for more robust measures of metabolic health. And part of this use of BMI as a screening but not diagnostic tool comes from the fact that although there are many strengths to BMI, there are also many significant limitations. Some of the strengths are that it's very easy to administer. As we saw previously, BMI is strongly correlated with percent body fat, so it does give us a proxy for body composition, and we know that obese classification is predictive of morbidity and mortality. But there are limitations. In particular, we know that a larger body is not necessarily an unhealthy body, so solely basing our judgment of health on BMI is limited and may be inaccurate. In addition, BMI does not distinguish between fat and muscle mass, so an individual with a very high muscle mass, such as an athlete or a bodybuilder, may technically have a BMI classified as obese, but they don't have excessive body fat, as the term obese implies. BMI also does not identify where fat is distributed. We know that centrally located fat, as would be indicated by a waist circumference measure or a body composition scan, is much more dangerous than fat located elsewhere. In addition, many of the consequences of obesity are mediated by metabolic or social factors and not higher weight per se. So it's important that we obtain additional measures of metabolic or behavioral risks that would provide a better understanding of whether that individual is in need of support and what support is appropriate. Other important indicators of metabolic risk are more robust measures of body fat and metabolic health. So if an individual has a BMI that's classified in the obese categories, we would want to follow up with some of these additional assessments. High percent body fat can be assessed by measures such as DEXA scans, BOD-POD assessments, skin fold measurements, bioelectrical impedance analysis, and waist circumference, all of which give us more robust measures of body composition and fat distribution. We can also analyze blood and look at lipid panels to determine whether an individual has high LDL cholesterol, low HDL cholesterol, or high triglycerides. We also would want to screen for impaired glucose regulation, which can be assessed by HbA1c tests, fasting glucose tests, or oral glucose tolerance tests. So it's important to note that these biomarkers can help us distinguish the patients who are at highest risk and in need of support versus those who maybe just need some further monitoring. In particular, we may have patients who are metabolically healthy obese, meaning that they may have a higher BMI and higher fat mass, but otherwise they are metabolically healthy, and thus maybe just need continued monitoring and screening. These patients should be distinguished from those who have high BMI and high fat mass, but also other metabolic risk factors such as high visceral fat, low insulin sensitivity, low HDL cholesterol, and high triglycerides. These at-risk obese are the patients that we want to identify and support through behavioral and medical intervention. So let's wrap up with some key takeaways from this lecture. First, BMI, which is calculated as weight divided by height squared, is a commonly used weight status metric, but it's a screening tool, not a diagnosis, and we use it to identify individuals in need of further assessment. We can use raw BMI to determine weight status, and this BMI can be classified into different weight status classifications. For infants and children, our approach is a little bit different. We need to standardize BMI to account for normal developmental differences in body composition. To standardize BMI, we want to use the appropriate growth charts. For infants under 2 years of age, we use the WHO growth standards, whereas for children between 2 and 20 years of age, we use the CDC growth references. When an individual has a BMI classified as obese, this signals the need for further behavioral and metabolic assessment. We can use these more robust measures of risk to determine whether intervention is needed and what intervention is appropriate. Thank you for learning with me.